for sake of time, I'm going to move on. Thanks for your patience, Dr. Reed, to our pathology conference with Seattle Children's faculty.
Hello, thank you very much for inviting us. My name is Robin Reed, and I am a pediatric pathologist at Seattle Children's Hospital, and I and several of my nephrology colleagues here are going to be presenting some cases today. I shall share my screen, hopefully. All right, is that displaying the way that it ought to?
That's good.
Yay, okay, excellent. We have nothing to disclose, and we are going to be presenting 3 cases today, and we will start with Dr. Okamura presenting a case.
Robin, I don't know. Yeah, you have control. Okay. So our first patient, he's a 17-year-old male who was otherwise healthy until about 2 months ago when he just started not feeling well. He had some epistaxis and sort of daily blood clots. And then 1.5 months prior to getting admitted, he was seen in the urgent care for vomiting and abdominal pain. At that time, he did have a slightly elevated creatinine of 1.1. He did have 1+ protein in occult blood. We couldn't get too many records from that, and so no treatment was really done. And then a month prior to admission, he had some URI symptoms, some cough and shortness of breath, and he was diagnosed with walking pneumonia and put on some antibiotics. He was also prescribed some albuterol, which made him feel better, and the antibiotics, he thought, made him feel a little bit better, but he still had a cough. And then about 3 weeks prior to admission, he started having some vomiting, sometimes up to 8 times a day, as well as some abdominal pain, headache, and back pain. He did take some ibuprofen for those complaints. He also stated he was having some tactile fevers and night sweats and really poor energy with some malaise. He actually lost quite a bit of weight over the last 3 months that he's been sick. When we saw him, he was down 27 kilos from a previous weight in August. He also had some muscle pain, especially in his lower legs. And his mom noticed that his eyes did look a little swollen. And when they queried him, he did admit that his urine output was a little bit lower and he thought his urine looked dark. As I said, he still had that cough and some nasal congestion and shortness of breath. And he was also starting to get quite tired when he would even climb up one flight of stairs, and was also having some chest discomfort. Really no joint complaints, no diarrhea, no hematochezia, hematemesis, or hemoptysis. He was looking so bad, but he was sort of a minimizer, but his grandmother and uncle really forced him to get evaluated, which is how he went to an outside ER. Really, his past medical family and family history are pretty unremarkable, and he's a senior in high school. Next slide. So on physical exam, he was afebrile when he showed up here. He was a bit tachycardic at 120. Blood pressure was okay. He was a bit tachypnic, but he had 100% SATs on room air. He was awake and alert, but he didn't look so good. He looked ill. He definitely had some periorbital edema, no nasal ulcers or anything in his mouth. He was in some mild to moderate respiratory distress with some tachypnea, and he had notable diminished breath sounds in the right lower lobe. He was tachycardic, but his rhythm was regular, no gallop, and the rest of his exam was pretty unremarkable. There's his labs as you see it before, and I'll just sort of draw upon the things that are significant. So his potassium was a little bit low at 3. Obviously, his creatinine was elevated at 3.1. His BUN's not so elevated at 26. He was quite anemic with a hemoglobin of 6.8. Both his ESR and his CRP was elevated. And he was negative for COVID flu, and our whole respiratory viral panel was negative. He was a bit hypocalcemic, at 7.6, and his albumin was low at 3.1. His total bili was a little bit elevated at 1.7. Because of his cardiac complaints, he had his BNP and his troponin check, both were negative. His PT was elevated at 17.3, but his INR was normal. PTT was a little bit elevated. Fibrinogen and D-dimer were both up. And then his urine, we had samples that were sent to the lab, as well as our on-call nephrologist had a look at it. He had both blood protein and bilirubin in his urine. He had quite a bit of hematuria, as well as pyuria. And although the lab read some white cell casts, we didn't see any white cell casts. It was mostly granular casts, waxy casts, and some hyaline casts. And his UPC was 0.6. Next slide. So he had quite a bit of imaging. So because of his chest complaints and his coughing, he had a chest X-ray that showed this abnormal opacity on the right side of his chest for some concerns of some multilobar pneumonia that was done at the outside hospital. Then he had a CT of his chest, which showed this scattered areas of consolidation in multiple lobes, especially in the right lower lobe, and in the left lingula, there were pneumatoceles and diffuse bronchiectasis, but nothing that looked like pulmonary hemorrhage. There were no ground glass opacities. His CT just showed some mild URI to maxillary sinus thickening, but no bony breakdown or anything that looked suspicious for vasculitis. His kidneys were enlarged and echogenic. And then you can see the rest of his laboratory workup there below. The significant things were that his IgA was a little bit elevated, but his IgE was tremendously elevated at 5,327. Complements were normal. His lysozyme was elevated. His ANA was negative, and his C-ANCA was very positive, and his PR3 was off the charts. Any questions about that?
Darrell, I may have missed this, but his eosinophil count, was it elevated as well?
Actually, it was not. Well, if you look at the absolute, his absolute was like about 330, 340, but the percentage was normal. Never really reached some anything very elevated.
Darrell, I'm seeing a question in the chat. Was there any evidence of cold agglutinin disease? And was the walking pneumonia real?
I don't think the walking pneumonia, I mean, he definitely had something going on in that side of his lungs. He didn't have any significant long-term pulmonary history. He did admit that he had been coughing, for quite a long time, but no asthma, nothing like that. I don't think they check cold agglutinin. I'm pretty sure he did get azithromycin. Not that we know of. I think he, I forget if he had any drug tests, but he did not admit to any illicit drug use. All right, next slide. Gets pretty interesting. So, because of those chest X-ray findings, he got placed on antibiotics. He had an initial EKG because of his his chest complaints, which just showed a non-specific Q-wave abnormality. The QT was totally normal. And then, we got back about the same time we got back. We pushed the lab to get his all his ANCA studies back. And so that's the ones that I showed you there. And so because of what was going on in the chest, we were a little bit reticent to immediately start him on therapy. So we wanted to get taken for a bronchoscopy as well as a renal biopsy. So that morning, as we were getting ready to take him for procedure, he started earlier in the night, he started feeling nauseated and he was vomiting and having a lot of body aches and chest pain. He got some Zofran for the vomiting, and then he had some abnormalities that looked like was going on the monitor, and so they did a repeat EKG, which then showed a prolonged QT, and he was just not looking good. So they made arrangements to sort of transfer him to the PICU because his work of breathing was getting worse and he was desaturating, requiring oxygen. And then he went into VTAC with looked like torsades, and then he had a seizure. Actually, our nephrology fellow was there at the moment and started doing compressions. They called the code. He was able to reach sinus rhythm after several episodes of defib and got a lot of medications for his arrhythmia. He was unstable enough, it was thought that he should go on to ECMO. And so they cannulated him and put him on ECMO. As I mentioned, his troponins were normal on admission, but after CPR, it was 6.4. His troponin was elevated, and the next day was up to 11.6. His BNP that was initially normal was increased to 693 the following day. And then we brought in his antibiotics. He got a better echo the next day, which showed some mild to moderate dilation of his right coronary artery. They really could not see the left coronary artery very well. And he definitely had depressed systolic function. That was like old. And so given the multi-system involvement, we thought about what his disease was. We pulsed him with methylpred and started him on TPE as well as Cytoxan. He was able to get off of ECMO actually in a relatively quick fashion, I would say, given how sick he was. He was off by about day 8, 3 days later, 4 days later. But he remained oliguric and stayed on CRT and got TPE. By day 11, we're able to get him to cardiac cath, which showed a complete occlusion of his right coronary artery with a lot of nodularity and tortuosity, also in the left main, and the LAD and the circumflex. He had quite a bit of collaterals in there. And so those significant cardiac involvement really, as we saw in the echo, really made us think about what his actual diagnosis was. And so we did a renal biopsy. Any questions?
Sorry, I may have missed. Did he have eosinophilia?
Yeah, Ashley asked that question. So he had his initial absolute count was like about 330, 340. So it was like minimally elevated, but the percentage wasn't that elevated. Percentage was normal, I should say. And that was probably the most significant amount of eosinophilia he had.
Did he have a chest CT?
The chest CT showed.
Sorry, specifically looking at the vasculature in his chest.
He did not. He later, not at the immediate. He later on did have a CT of his abdomen with contrast. So as people are probably getting to, so our differential was basically GPA or ANCA vasculitis, EGPA, and then possible polyarteritis nodosa or PAN. So he got a scan to see if he had anything in his lower abdomen that was abnormal, which it was not.
All right, let's look at some biopsies. I'm going to start every case here with a low magnification trichrome view just to give you an overview of how the kidney looked. And at low magnification, what you should be able to appreciate in this kidney is that we've got pretty well preserved interstitium without significant interstitial fibrosis. There seems to be some tubular injury, so these tubules look sort of gaping as though the epithelium has been injured and is regenerating. And the other thing that's striking at low magnification here is that these glomeruli look unusually blue in this trichrome stain, like there's something weird going on with them. Looking at them more closely, about 2/3 of the glomeruli look entirely normal. There's really nothing wrong with some of the glomeruli. Among the ones that are affected, we see a range of changes, all of which are consistent with crescentic glomerulonephritis, but showing kind of a range of age of the lesions. So a small minority of the glomeruli had cellular crescents in them. But in the majority, when there was crescent formation, it was either fibrous or fibrocellular. And again, here you can see that there's also some acute tubular injury that's ongoing. So we saw a number of glomeruli that looked as though they had been almost entirely destroyed with destruction of Bowman's capsule and fibrocellular or fibrous crescent formation. Here's an example of a Jones stain of one where, again, you can see kind of a fibrocellular crescent. Here's a glomerulus that was basically completely destroyed and one with a much smaller lesion. And then this, again, is illustrating these areas of tubular injury. There was immunofluorescence staining on this case was entirely negative, and our electron microscopy was also essentially negative with well-preserved glomerular basement membranes in non-crescentic areas, well-preserved foot processes, and no electron-dense deposition. So based on the serology and the histology here, this was post-immune glomerulonephritis, consistent with ANCA glomerulonephritis. But unlike many cases of ANCA glomerulonephritis we see, in this case, the vast majority of the crescents present were fibrocellular and fibrous rather than cellular. So about 1/3 of the glomeruli were involved by crescents. And importantly, we did not see any eosinophils in the interstitium or in the glomeruli. We did not see any granulomas. We did not see any vasculitis in our sample. And then also, there was also acute tubular injury, which I think is probably attributable to his cardiac instability and his code 14 days prior to the biopsy. I've got a slide on cardiac involvement in ANCA-associated vasculitis, but Daryl, do you want to talk about what clinical considerations, or should I talk about this first? Your sound's off.
Yeah, no, I can talk about it. Yeah, for sure. So, you know, he was a bit, as we're going through it, we really sort of, especially when his IgE level came back, we still don't know for sure, because in EGPA, you can have a range of findings on renal biopsy, which could be that, but EGPA rarely has, are rarely PR3 positive. They're typically MPO positive if they're positive. So we're a bit of a quandary. The only thing that we were debating about is whether he needed any specific EGPA type treatment with mepolizumab or forget the other mab that that you can get, but we decided that there were stronger indications to try to treat him more like a typical GPA, so we decided against that and just treated him. He got a lot more pred than we typically would give, but he was very sick. So he got 5 days of 1 gram of methylpred. Got Cytoxan every 2 weeks for 3 doses, and then rituximab. As I mentioned, he got TPE, got 7 sessions of TPE. He's responded incredibly. He is creatinine's down to 1.1. He's been off any dialysis for about a week now. He's been in the hospital for a little over 3 weeks. And he's gonna go home soon, and then we'll start him on avacopan when he gets out, or we'll try to get approval for it because he's like about 4 months short of 18. We think we can get it approved.
When I read about cardiac involvement in ANCA-associated vasculitis, what I learned is what Daryl already knew, which is that the great majority of these cases are in eosinophilic GPA, where the condition is usually a cardiomyopathy due to eosinophilic myocarditis with like microvascular inflammation. When you see cardiac involvement in PR3 positive GPA, like in this case, it's usually pericarditis, sometimes myocarditis or valve disease or conduction block. I didn't find a lot of literature on coronary artery involvement in GPA, so I thought that was interesting and an unusual manifestation. But it's worth noting that following ANCA-associated vasculitis, there is a substantial increased risk of cardiovascular events in all comers, where if you look at like 5-year follow-up, up to 14% of them have a cardiovascular event of one sort or another. That's less common in GPA than it is in eosinophilic GPA or in microscopic polyangiitis with like MPO. But yeah, I think this was an unusual manifestation of this disease for sure.
Yeah, for sure. I actually, I mean, several years ago, I got called from one of our former fellows for a patient who that they thought that patient was actually MPO positive, but had coronary artery involvement as well, which made us jump on this a lot earlier because of that. In regards to Kawasaki's, I mean Kawasaki's, you can have some sterile pyuria, but it doesn't give you a chronic GN like this had. We did give IVIG though, for that very reason.
Daryl, I'm struck by the very high IgE levels. Not something I typically think of in PR3 ANCA vasculitis.
Yeah.
Any other thoughts about that?
Yeah, I mean, exactly. I mean, that really pushed the eGPA discussion, up a lot. At that point, we were sort of hemming and hawing about the, absolute eosinophilia. And then the IgE came back. And so we really had a long, hard discussion about whether he needed, more eGPA specific therapy, because that was really unusual. Yeah, I mean, I've also never seen it. And, we have checked, total immunoglobulins before on other patients. I've never seen one that high who didn't have GPA. So we'll have to see, as us and the rheumatologists have talked about, is just sort of keeping our differential open. Surely his lung findings with the chronic, with the bronchiectasis made us also think about whether he had eGPA. There is a family history of asthma, and he was responding to albuterol. So it's really hard to say. He's sort of a minimizer, so we don't know, how much complaints he really had. So we're gonna have to just watch that going forward and see what organs, see how he responds to therapy.
Yeah, because I wonder if the eosinophil count had been just slightly higher, whether you would have labeled him as eGPA rather than PR3 ANCA.
I know. It was such a quandary, so, I talked to the rheumatologist of whether we should check an IL-5 level or something like that. But they didn't want to do it. So, but yeah, for sure. I think, eGPA was right up there.
Yeah.
Yeah, I would say we still don't know for sure what his diagnosis is.
His biopsy just didn't have a single eosinophil in it, pretty much. But I don't know whether that's mandatory for the diagnosis of eGPA or not.
Well, he got a lot of pred, and eosinophils will
right,
just shrink away with, and he got a lot of pred prior to that, so it would make it go complete. And that's what you see. We saw whatever eosinophils he had in his peripheral blood was gone after the method.
Oh, okay. So it's possible that they were there before, yeah.
It's possible they were there before. Yeah. So it's hard to say.
All right. Should we talk about the next case? The next case will be presented by Dr. Simons, and it is allograft dysfunction in a 3-year-old with end-stage kidney disease due to congenital nephrotic syndrome.
Okay, thanks, Robin, and good morning, everybody. Thanks for the opportunity to present this case. We'll go on to the next slide where we'll present the clinical information on this child. This kiddo came to us first when he was 3 weeks old. He was a former 35-week gestation, and he was at home doing fine, but then developed seizures. This was back in October of 2019. And when he came to our hospital and was admitted to our neonatal unit for ongoing care at 3 weeks, he was profoundly hypocalcemic, ionized fractions around 0.7, and a total calcium of around 4.4, 4.5. And our neonatology colleagues treated him for his hypocalcemia and pursued the question as to whether or not he had maybe DeGeorge syndrome or some other reason for persistent hypocalcemia. And as part of their evaluation, he ended up getting an ultrasound of his kidneys, which were noted to be echogenic, and that prompted them to check his urine, which was positive for protein and also for blood on dipstick. His creatinine was 0.2, which would be pretty normal for a baby at this size and this age. And then eventually, after a little bit, checked his albumin, and it was that's a typo there, 1 gram per deciliter. And he started getting edematous as we gave him fluids, and all of that made them give us a call. So that's when we got involved and saw the patient, and it looked like he very likely had one of the forms of congenital nephrotic syndrome. We did genetic testing on this patient, and he was found to have variants in the NPHS1 gene, which codes for nephrin. He had one variant which was well described as being pathogenic, and another variant that had not previously been described but was likely pathogenic and seemed to line up with his clinical presentation. And so we made, based on the genetic testing, the diagnosis of nephrin deficient congenital nephrotic syndrome, and proceeded to keep taking care of this baby in a conservative manner by using albumin and furosemide infusions, trying to optimize his nutrition, and treating him with ACE inhibitors and indomethacin in an effort to try to reduce his protein excretion. But with conservative management, which works with some children and can be really successful for those who don't have very profound nephrotic syndrome, unfortunately, this didn't really work for this child. He had really very poor growth, and it was really a problem to try to get him to thrive. And so we find ourselves sometimes in the position of saying that a child is going to do better as an anephric dialysis patient rather than a profoundly nephrotic, congenital nephrotic patient who's at big risk for complications as well as not growing. So this child underwent, after a lot of conservative management, ultimately bilateral nephrectomy, moved on to hemodialysis for a while, had a PD catheter placed because we thought peritoneal dialysis was a better modality for him. And then he moved on to peritoneal dialysis a couple of months later after the PD catheter had healed and the family had their training. And he actually did rather well on PD. And the family did a great job taking care of him. And he really did well as a PD patient until he got COVID and got very sick. And unfortunately developed sort of as a theme for today, coronary artery disease. His was dilatation, and the question was whether he was one of those children who had MISC, the multisystem inflammatory syndrome that we sometimes see in children, and our cardiology friends got quite involved in his care. He did improve and ultimately went home and continued on dialysis. And then eventually in June of 2022, he got a call for a deceased donor transplant and ended up going to the operating room to get a transplant and did pretty well. Next slide, please, Robin. So here's just some information about his transplant. Our recipient is a B positive patient who was EBV negative and CMV positive going into transplant. The donor was blood type B, EBV, and CMV positive. Next one, please, Robin. Here's a listing of the HLA typing between recipient and donor. You can see the areas which are mismatched and a couple of places where there is a match. Next one. And then in the operating room, the warm ischemia time was 50 minutes. The cold ischemia time was just a little over 6 hours. Our standard induction includes antithymocyte globulin and methylprednisolone. He did really quite well in the operating room, lots of urine, and recovered very nicely and was discharged home after about 10 days in hospital on Tacro and MMF, which was our standard immunosuppression. And he did great. Next slide. And over the next couple of months, this is the pattern of his serum creatinine. And it looks like it's all over the place, although the range is not super huge, maybe compared to some of your larger patients. You'll notice he initially had creatinines of about 0.3 milligram per deciliter when he first came out of the operating room, and then seemed to settle, we thought, closer around 0.4 milligram per deciliter. But over the 3-month period, there were 1 or 2 times when it seemed to go up, and we would try to see if we could fix his volume status, double check his tacro levels, all the things we usually do. They seem to improve, but it depends on how cynical you are when you look back at the numbers and decide whether values around 0.4, 0.5 are maybe higher than they really should have been for this patient. In our program, we prepare for surveillance biopsies at 3 months post-transplant, and we were getting ready to do that when, next one, please, Robin, we got a result which showed us that he was now very strongly positive for donor-specific antibodies at the DQ02 channel. With that very high MFI and looking back at his creatinine pattern, we were getting ready to do a biopsy, and we decided to be a little bit more aggressive, use the slightly larger needle, and see if we could figure out what's going on. So next slide, please, Robin. So we decided then to do his biopsy. Robin will show us the pathology. I'll pause for a minute, though, and see if there are any questions about the case.
There is a question in the chat. Did he have proteinuria?
No, this patient did not have proteinuria at this time. Tons of it before, but once we took out his native kidneys, that went away, and he did not have proteinuria in from his allograft.
And this biopsy was taken about 3 months post-transplant?
Yes, that's correct.
All right. So at low magnification, we don't have a ton of cortex to look at in this kidney, but what we can see of the kidney looks like there is something going on interstitially in places. It looks a little busy, and like the tubules are being kind of squeezed apart by cellular infiltrates. And no obvious interstitial fibrosis and no obvious tubular atrophy. Looking more closely in this H&E image, what I want to show you is that overall there were patchy but occasionally rather dense interstitial infiltrates, which consisted of lymphocytes and some eosinophils in there as well. And then there were areas where these seemed to infiltrate tubules, probably about 25% of the parenchyma, so enough that you could entertain a diagnosis of cellular rejection. This is another image, again, showing an area of these sort of patchy infiltrates and a little bit of tubular atrophy, but generally speaking, the cortical tubules were pretty well preserved. Despite the interstitial inflammation, there was not a lot of tubulitis in this kidney. So my kind of stepwise algorithm for evaluating acute T-cell mediated rejection is, first of all, is there interstitial inflammation? If there's sufficient interstitial inflammation, so more than about 25% of the well-preserved cortex, then I move on and I ask, okay, is there tubulitis? Because in T-cell mediated rejection, tubulointerstitial rejection is the most common form. There was like a smidge of tubulitis here. We found occasional tubules with like 1 to 4 lymphocytes, but nothing that got us to T2 tubulitis. So it kind of didn't clear that bar to think about acute T-cell mediated rejection grade 1A. That said, however, the one thing we did discover was an artery that looks like this. So this is a large artery. I'm showing you an H&E and a trichrome image here. And you can see that there's brisk mononuclear cell infiltrates in the intima and into the media of this large artery. So despite the fact that there doesn't seem to be tubulitis, there was significant vasculitis. This is actually, by Banff criteria, this is a V2 lesion because there's some expansion of the intima and obstruction of the arterial lumen. There was not fibrinoid necrosis, so it was not a V3 lesion. So in addition to this, this arteritis, the other finding in this biopsy was that we did see some peritubular capillaritis. And I'm showing you that here. So here is a peritubular capillary with a lot of mononuclear cells. Here's one with a few, another profile here, some profiles down here. It wasn't the most raging peritubular capillaritis you'll ever see in your life, but there was a respectable amount of it. However, the C4D stain was negative in this case. So we kind of scratched our heads because this isn't a pattern we see super often where it looks like there was significant vasculitis. There was not significant tubulitis. And so, by Banff criteria, this definitely qualified as T-cell mediated rejection grade 2B because there was interstitial inflammation and there was this arteritis, but it is an unusual pattern for us. And then additionally, we saw peritubular capillaritis with a C4D negative result. We commented that the arteritis seemed to be out of proportion to tubular inflammation. That can happen. Banff describes the concept of the so-called isolated V lesion. This doesn't exactly meet that criterion because there's actually too much interstitial inflammation for it to be a isolated V lesion, but it is unusual for us. So we considered, in addition to the sort of orthodox interpretation that this is cellular rejection, we also considered the possibility that this could be antibody-mediated rejection. Additionally, sometimes arteritis has been described not like within a couple of months of transplant, and in a way that appears to be perhaps possibly ischemic injury. So we also mentioned that possibility. And this was a paper that we read that we thought was helpful in kind of understanding so-called isolated V lesions in kidney transplant. So yeah, there's certainly something going on here, and we weren't entirely sure what it was. Now I'll bounce it back to Dr. Simons.
Okay, thank you, Robin. So we were a little confused, and it seemed to be sort of a mixed picture. And with a mixed picture, you always ask yourself, what are you going to do? And we kind of did everything. So given everything that was going on and the concerns that it could be cell-mediated and maybe also antibody-mediated rejection, we did treat this patient pretty aggressively. There was a question in the chat also about his EBV PCR, and that, along with CMV and BK testing, was negative. We thought since this was kind of a funny-looking biopsy, we sent AT1 receptor antibodies to see what was going on. That's not something that lives in our wheelhouse and that we thought about much in our patients, but it looked weird, and we thought, we better check everything. And we did treat this patient with anti-thymocyclobulin, IVIG, rituximab, and he is now then went home on Tacro and MMF, but we added prednisone to his regimen, thinking that he clearly looked on his biopsy like he was under immunosuppressed, and his creatinine, which still bounces around a little bit, partly depending on what his Tacro level happens to be, is leveled off at around 0.5, which was his most recent number just a couple of weeks ago. Next slide, please, Robin. Since we started treating the patient, this has been the progress of his donor-specific antibodies. You'll see when we did this biopsy in September, the MFI was quite high, and it's come down progressively after his treatment, but still there. And then next one, please. And then we got this little surprise too, which is it turns out that his AT1 antibodies are positive. And I think we may have one other patient in our program whom we've tested where that has also come back positive. This is a new thing for us. And we're trying to learn about this. And although the patient overall looks pretty stable right now after getting treatment for this process, would be interested if maybe there's a comment about how you handle this for your patients.
Yeah, and just a couple of notes on AT1R antibodies in kidney transplantation. This was a new one to me as well. This is probably much more old hat for the adult nephrologists and renal pathologists here. But I learned that AT1R antibodies are present both pre-transplant and post-transplant. There may be some evidence that they can bump post-transplantation, perhaps potentiated by development of donor-specific antibodies, although it sounds like that's still sort of unclear in the literature. And the prevalence range for these antibodies is incredibly wide, depending on like the study methodology and the population that you're looking at. And I actually don't know what it is in kids, and it's not something that, as Jordan said, it's not something that we test for super often. AT1 our antibodies are associated with antibody-mediated rejection, and some studies also show that they can potentiate T-cell-mediated rejection. The antibody-mediated rejection pattern is often C4D negative. But you can also get this co-occurrence with donor-specific antibodies. And from what I read, it sounds as though when you have both together, it makes graft rejection, the probability of graft rejection higher, and it causes more histologic inflammation, which could go with what we were seeing in this case. So yeah, I'm going to kick it to our audience to tell us how you guys approach and handle these cases.
Yeah, I mean, this is very interesting. You know, the AT1R had been described initially in Germany cohort, a cohort from Germany that had maybe a similar histological picture to what you are showing. It's vascular rejection that was quite impressive. The clinical syndrome was obviously renal failure and the hypertensive syndrome was thought to be more vascular. And then there's been a lot of interest, including ours. We also, you know, most of the data that followed was kind of a retrospective data looking at association between the AT1R antibodies and rejection. And yeah, we also found an association with AT1R antibodies, but we were actually questioning if this is a pathogenic association versus an association that's more kind of you know, bystander. The problem with AT1R is the testing. Testing is not validated. It has been, you know, we actually dropped testing a while back once our HLA lab has looked at the accuracy of the testing, which was very, very poor. There've been actually some lots of the ELISA testing that was completely withdrawn from the market at some point, and now, yeah, I don't know. The company's been bought by we've not used it. One thing that I want to mention is that the prevalence of these antibodies in living donors is 80%. So again, we found the association with features that may be more prone to rejection. So younger patients, less time on dialysis, non-diabetics, more likely to have autoimmune disorders. So kind of like the factors that you would think that someone will have a stronger immune system. And I'm still questioning this. However, the level that you found is definitely outside of the range. So when I'm talking about positive, I'm talking about values over 10. You know, for our cohort, over 10 was the cutoff for rejection. So yeah, more than 40 is definitely a very high value. But again, I'm putting a question mark on the accuracy of the testing.
Thanks, Nikolai. I appreciate the comments and the insight.
Yeah.
Okay, thank you, everybody.
A good rule of thumb in laboratory testing is that sometimes abnormal values are abnormal for spurious reasons or for non-physiologic reasons, but the greater the deviation from the normal, the greater the burden of explanation it is on us to explain it away and not take it seriously. So it feels like this is pretty far off of normal, for what that's worth.
Hey, Jordan, is there an age cutoff where you would not, do a trial of steroids first?
I think if you're a pediatric patient and you end up in our program, we give steroids like water. So no, there's a lot. And I think this guy got, I think the reason we were concerned was just that everything looked really aggressive, and we decided to do, we had a big conversation about whether it was going to be steroids versus ATG, and we ended up going this way because we were really worried that he was having very aggressive disease. It's interesting in retrospect. Again, we wonder if we were wrong, but almost everybody gets steroids first.
I'm sorry, I meant like his original presentation before transplant. Sorry.
Thanks. My apologies, and thanks for clarifying. No, we when you present at less than a year of age, it's much more likely to be one of these genetic diseases. And so we lean towards genetic testing now because we can do it so quickly. And I don't have to tell you that. So that's something that really helps us out. And if we know that there's the defect, that's so unlikely to be a responsive disease that, yeah, we tend not to pursue. Robin, one more case. Should we move on?
Let's do it. All right, last case. This is a 9-year-old with new onset recurrent gross hematuria.
Okay, next slide, please. And I think this case was going to be presented by my colleague, Rebecca Yorton-Colbert, but unfortunately she got called away to take care of patients this morning. So I'm pinch hitting. This is a 9-year-old boy who was previously well and presented with fever and gross hematuria. I'm going to let Robin click through these slides here until we get all of the text up. And basically the story was he kept coming to his pediatrician because he was sick. And the thought was maybe he had recurrent urinary tract infections. He kept getting antibiotics. He just didn't seem to get better, and kept showing up at the doctor or at the emergency department, and had concerns also because he had intermittent episodes of gross hematuria. There was worries as to whether or not he might have actually had pyelonephritis because of some of the findings on his imaging studies. And then ultimately he came to our hospital with findings that were much more concerning, which included blood testing with a very elevated creatinine. I think it peaked up at around 7, and that's around when we got involved because clearly something was up here. Next slide. Again, his kidneys had looked a little bit unhappy previously when there was more concern that he might have had pyelonephritis. They still showed big kidneys that were kind of echogenic bilaterally. He had findings which seemed to be consistent with an acute glomerulonephritis when he finally came to nephrology attention. And with all of that, we decided that what this guy really needed was a kidney biopsy to figure out what was going on.
Yeah, so here's his kidney biopsy. At low magnification, you get an impression of maybe some interstitial edema, and the glomeruli look funny, but there's no chronic changes that are visible, at least from orbit here. Looking in more closely, this kidney is overwhelmed by a necrotizing and crescentic glomerulonephritis. In contrast to our first case, all the crescents here look really fresh for the most part. There's a lot of necrotizing lesions, and there's a lot of cellular crescents. There's this brisk kind of interstitial inflammation, and not a lot of chronicity. 95% of the glomeruli were involved by necrotizing and/or crescentic lesions. Here's a glomerulus with a small necrotizing lesion. The fibrin is showing up as red. Here's one that's just about destroyed. Here's one with a necrotizing lesion with fibrin, and here's another one. And this is another glomerulus that's also having a bad day. And you can see that there's some interstitial and tubular there's interstitial edema and some tubular injury going on here too. There's a lot of glomerular basement membrane rupture and destruction going on in places where you can see basement membrane. It kind of abruptly ends, and there's a lot of destruction, sometimes with Bowman's capsule as well. Here's another example, and I think I chose this picture to show that there's a number of acute inflammatory cells in some of these crescentic lesions, again, just highlighting that many of these are very fresh. Every so often, a little bit more chronicity, yeah, but not very much. It all looks like it's pretty acute and ongoing, and there's a lot of interstitial inflammation and interstitial hemorrhage even. The immunofluorescence in this case showed linear staining of the glomerular basement membranes, brightest for IgG, but also fairly robust staining for IgA in this glomerulus that's involved by a crescentic lesion. You can see this one is as well. There was weaker but still present linear staining for IgM, and fairly bright staining linear for C3, and some faint C4 staining. Electron microscopy showed normal appearing glomerular basement membranes with no immune complex depositions identified. So this is crescentic glomerulonephritis that had immunofluorescence findings consistent with anti-GBM glomerulonephritis. And as I said, 95% of the glomeruli here were involved by necrotizing and/or crescentic lesions. Not a thing we see very often.
Thanks, Robin. So, yep, we don't see it very often, and he's 9, so it's not a disease that he's really supposed to be having. At around the same time that he went for his kidney biopsy, the results came back for his serologies, which included positive findings for his anti-GBM. His ANCA, I believe, was negative, if I remember correctly. So he's not a double positive patient. So anti-GBM positive, ANCA negative. He got the full meal deal for treatment, including plasmapheresis, cyclophosphamide, and steroids, and went home with ongoing treatment with MMF, with a plan to finish up, I believe, next month. And he's gotten quite a bit better than when he was in the hospital. Next slide, please, Robin. So just to sort of show you the trend of his data, you can see where his creatinine was up around 7.5 when he showed up in our hospital, compared to completely normal findings on some other blood testing that was done way before when he had been less sick. With the therapy, creatinine came down very nicely, but not anywhere near normal. And he's left with a creatinine between 1.5 and 2 and an estimated GFR of around 30 mils a minute. Proteinuria has improved significantly, although it hasn't gone to zero. And you can see the bottom graph is his anti-GBM findings, which was a high number because there's a dot you can see up there, and then it vanishes behind that silly screenshot word there and becomes a bunch of question marks. Then it's question marks because it's ungraphable, because it's undetectable. So that went away. So at this point, we have this patient who seems to have improved clinically, but is left with a creatinine between 1.5 and 2 and a suboptimal GFR. And my colleagues who care for him are getting him ready for assessment by our transplant program. And there we are.
Yeah. Well, and one would infer from the state of his biopsy that he's probably got way fewer functional glomeruli than he used to have, because, you know, maybe some of these would come back, but that one's not coming back. That one's not looking so good either. There were a lot of really very extensively destroyed glomeruli here, so it's not surprising that he's left with chronic kidney disease given the appearance of that biopsy. There's a question in the chat, what would a dual positivity imply?
Yeah, so patients who are positive for ANCA and positive for anti-GBM, by some reports, have a more aggressive outcome. Part of it depends on, I think when we've sort of dealt with this before, is whether there are risks for relapse, really. So in a patient who goes to end stage right away, it's what's there, as someone else has mentioned in the chat, is their risk for relapse post-transplant with ANCA disease. In regards to patients who don't go to end stage, it's whether they need to remain on any long-term immunosuppression or not. Patients with ANCA disease, we tend to keep on some immunosuppression. We've had a few patients over the years who are dual positive. We really rely on what the biopsy is showing. Is the biopsy really showing a more of a posse-immune ANCA type presentation, or is it really consistent with anti-GBM? And so we've relied on that for the patients who are dual positive, on whether they need a little bit more immunosuppression to stay on something, versus patients with anti-GBM, we tend to take them off.
Mm-hmm. It's interesting. The nephrology fellows at Seattle Children's present kind of a disease of the month in our conference, and then I try and show some example cases of it. And when they presented anti-GBM 3 or 4 months ago, it was like 4 months ago at this point, I had to go back in our archives, I think about 4 years, to find our last anti-GBM case, maybe longer. It is not a common entity for us. I think I've seen it in the wild maybe twice. Yeah, it's uncommon. And I think the times I've seen it, I don't believe it was in somebody as young as 9.
And the response to treatment here is actually very good. It's probably better than we would expect in an adult with 97% glomeruli affected and a creatinine of 7. So the fact that they've recovered as much as they have is quite impressive.
Yeah.
Kids, that's why we love them. Great response to treatment.
It's true.
Well, that being probably a good summary of Pediatric Pathology Conference, we'll end there for time. but thank you. Great cases, beautiful images. Everyone have a great weekend, and we'll see you in the new year.
Thank you, everyone.
All right, thanks, everyone.
All right, bye.